So today I'm going to discuss about an approach to mammogram. Okay. So first, let's understand how a breast anatomy looks like, what all breast contains. Okay. So breast anteriorly it is made up of skin, and posteriorly it is made up of covered by the pectoral muscle, and in between we have this breast which has predominantly made up of this fat, and in between we have this fibroglandular tissue. Now this is how the breast is made up of. Okay, and the main unit here is the terminal duct lobular unit. There will be lobules and it will be connected to the terminal duct, and which will have this branching pattern. So this branching pattern is normally we see in the terminal duct lobule unit. Okay, so that's what we have to understand. Okay, zonal anatomy, just in brief, so this is what we are seeing here is the breast parenchyma, and whatever the black densities that we are seeing here is the fat. This is the subcutaneous fat, and similar fat will be present in the deeper to the fibroglandular tissue. That will be the deeper fat tissue. So the superficial fat is considered as the pre-mammary space, the space which is constituted by this fat. Subcutaneous fat is constituting the pre-mammary space, and the fibroglandular tissue, whatever the density that you are seeing is constituting the mammary zone, and behind the fibroglandular tissue, whatever the fat we are seeing is the retromammary zone. So this is how we divide the breast tissue. Now whenever we get a mammogram, we get the mammogram of the right breast and the left breast. In anything in radiology, this is always the right side, that is my left hand side. Sorry, this will be always the right. My left hand side is always the right. My right hand side will be always the left. So that's how normally any images in radiology is given. So in this image we will know that this is a right breast, this is the left breast. That's what we have to understand. Whenever we get an image, now this will be the right and this will be the left. Okay, then we know that there are different zones. But what we usually expect in a good mammogram is this fibroglandular tissue should be, or this mammary zone should have minimum fibroglandular tissue. It should have less fibroglandular tissue. When does this happen? This happens with the progress in the age. As the age increases, the fibroglandular tissue reduces. That's when this white density reduces. That's what we want whenever we do a mammogram. Why it is like that? If we see a white density in this area, it may not be seen clearly in the mammogram. But when there is a white density in this breast tissue, it is clearly seen. So ideally, we need a breast which is predominantly made up of fat. That's what we have to understand. Now, what BIRADS is a reporting system that has been started for standardizing the breast imaging. Okay, these BIRADS are there. BIRADS just means that breast imaging and reporting database system. So this is there for X-ray mammogram or sonomammogram, ultrasound, or it can be for MR mammogram. We always follow this BIRADS system, and there are BIRADS lexicon to describe different terms. Lexicon will tell us how to describe a particular lesion. So whenever we use this BIRADS lexicon, it becomes easy for us to understand. When someone is telling something, it is easy for other person to understand because it has a standard format. So that is what is BIRADS lexicon all about. Okay. Now BIRADS system is what we follow. Now whenever we start an imaging of a breast in a mammogram, first thing is you see for the breast densities. Now if a breast appears like this, it's almost completely made up of fat. Now this is a very good type of breast. This kind of breast imaging in this kind of breast is very easy. This is the type 1 type of the breast composition. The type 1 breast composition is when it is predominantly made up of fat and very less fibroglandular tissue. See that in the mammary zone, we are seeing very less fibroglandular tissue. Now in this, it is slightly more. Now we can see this area is made up of fibroglandular tissue. This area is made up of fibroglandular tissue predominantly. See, rest of the space is still made up of fat. Now here less than, this is having almost 25 to 50% of the breast made up of fibroglandular tissue. That's when we call it as type 2 breast composition. Now, if you see this breast, this is more than 50%, almost up to 75% of the breast is made up of the fibroglandular tissue. Now, this kind of breast becomes slightly difficult to interpret. This is a type 3 breast breast parenchyma. Okay, type 3 composition of the breast. Now, if you go to the next image, it is more than 75% of the breast is made up of this fibroglandular tissue. It is a dense breast, very difficult to identify any lesion. So, which is the best which type of the breast composition is best for imaging in breast? It will be type 1. Very simple. Lot of MCQs can come out of this. Which of the breast parenchyma is more sensitive for picking up the lesion? Type 1 breast parenchyma. Why? Very simple lesion, predominantly filled with fat. And if there is a small lesion here, we know we know that there is a lesion. Also, we can easily identify the composition of the lesion. Okay, so type 1 breast composition is a best breast composition that you can have whenever we are reporting a breast mammogram. Now, next thing that we have to see is whenever we see a breast mammogram, we have to identify a lesion, then we have to characterize the lesion, and we have to identify the associated findings in this breast. Now, once we do that, we divide the lesion, whatever we get, we find the lesion, we know that either this lesion can be benign or this lesion can be malignant. Okay. Now, one will be benign or normal, one will be a normal breast, and the 4 will be a malignant lesion. Whenever a lesion is there, if you put it 1, that is a normal breast. It's a normal breast. If I say 4, that means that there is a lesion which is looking like malignancy. Okay, 1 will be a normal breast, 4 will be having a lesion which is looking more like a malignant lesion. 2 will be a benign lesion, and 3 will be a probably benign lesion. Okay, it may not have all the features of malignant, but it is a probably benign lesion. These 2 lesions may not need much of follow-up, but probable lesion will need a proper follow-up or a biopsy. And type 4 lesion, definitely it will need a biopsy and it will need a treatment for it based on the biopsy report. So that will be the type 4 lesion, which is more like a malignant lesion. It is a malignant, whenever we say type 4, it means that very high features suggestive of malignancy. So that's when we call it type 4 lesion. There are something called type 5 and type 0. Type 0 is when this imaging is not enough for me to diagnose. I need more images. Either in mammogram itself, I want different angulations in the mammogram, or I want an ultrasound to assist me, or I want an old mammogram report. Whatever it is, whenever I cannot conclude by this imaging alone, I call it 0. I need help of other imaging. I need old images, or I need different angulation of the mammogram. That's when we call it a 0. But when I say 5, it is already a diagnosed lesion. It is already a diagnosed lesion, which is diagnosed as malignancy. Now, next thing is one. So, as I told, whenever it is 0, it needs additional imaging evaluation. My study is not yet complete. Now, whenever I say 1, that is normal breast. Whenever I say 2, then there are some benign findings. Whenever I say 3, it is probably benign. Now, whenever I say probably benign, then it still has some chances of it being malignancy. Less than 2%, but still it has some chances of it being malignancy. It needs a short-term follow-up. That's how important it becomes. Whenever I label it 3, then it needs follow-up. 3 and above, it is of concern, because even up to 2% of being malignancy, it is important for us. So we should not miss anything. Then whenever I label it 3, we will have to have a short-term follow-up. But whenever I give it 4, then definitely you will have to biopsy. Definite biopsy is required for this. and then whatever the further management is required, we'll do it. Now, this will have 3 to 94% chances of malignancy. Sorry, type 6 is biopsy prone, type 5 is very highly suggestive of malignancy. So type 4 and type 5 are highly suggestive of malignancy, and type 6 is when I say it is biopsy proven malignancy. Okay, now whenever I report any lesion now, so whenever we are seeing something in a mammogram, I have to label it something. Now, whenever I want to label it something, I use BIRADS mammography lexicon. Okay, BIRADS mammography lexicon considers multiple different findings. There can be a mass, there can be a calcification. When you cannot call it a mass, we can call it an asymmetric breast findings, or there can be an intramammillary lymph node, tubular densities, architectural distortions, and other integrated findings. Now, let's go one by one. First, let's discuss what is a mass. Now, mass is nothing but a space-occupied lesion seen in two different dimensions having convex borders. Very important. This definition becomes very important because a mass is anything that you see in a mammogram. It should have a convex outer border. This is convex outer border. Now, if it is something like this, it need not be a mass. Okay, it need not be a mass. Okay, it can be multiple glandular tissue which are compressed, and it might be looking like a mass, like a dense lesion there, but it may not be a mass. So it should have a outer convex outer border, and it should be seen in 2 dimensions. Whenever we are doing a breast imaging, we are doing it in 2 views. One is called craniocaudal view. One is mediolateral oblique view. Okay. Now, what exactly is craniocaudal view? When the breast is compressed from up and from down, you compress the breast like this and you make it flat. Okay. You compress from top and bottom and you make it flat, and you allow the X-rays from top cranio to caudal. So X-ray is going from cranial aspect to caudal aspect, and the detector is kept below. So craniocaudal view, the breast is compressed from up downwards. So breast is divided into a inner aspect and outer aspect. So whenever I do a craniocaudal view, I compress the breast from superior to inferior. Breast will be divided into inner half and outer half. When we see the image, the breast will be like a semicircle, and it will have an inner half and outer half. So we know that if anything is present in this half, that is from the inner aspect. Anything present in outer aspect of the breast, that is from the outer aspect. So that's how the craniocaudal view helps us to find whether the lesion is from the inner half or whether the lesion is from the outer half. Now, similarly, that is one plane. We want to do a lateral view, but complete lateral view is difficult to obtain. So we do slightly oblique view. So whenever you do an oblique view, consider it is something like a lateral view. The breast is compressed from lateral to medial aspect. Okay. Now what happens? Breast is again forming a semicircle, but it is from inferior to superior aspect. There is a semicircle in this manner. Okay, there is a semicircle in this manner. Now the image, whatever I get, I can divide it from the upper half and the lower half. So whenever in a mediolateral oblique view, if the lesion is in the upper half, we know that the lesion is from the upper half. In the craniocaudal view, we know that whether the lesion is from the inner half or the outer half. So based on that, we know that the lesion is in which quadrant. So that's how we identify lesion is in which quadrant. Again, I'll explain you when we go to the topics proper, we'll get to know each of these things. Now, first thing that I told you is whenever there is a lesion which has a convex outer border, and it is seen in 2 orthogonal planes, that is in the craniocaudal view as well as in the oblique view, that is when we call it as a mass. It should be seen in 2 different projections and it should have convex borders. That's when we call it as mass. So if it doesn't have, then what we call it, that I tell you later. Now let's concentrate on the mass. So whenever there is a mass, we give always a size, then you see the shape, margin, calcification in it, and density. Now again, as we saw in the breast image of a breast, see, this is a breast image. Okay, what we are seeing is this is fat. Okay, so fat is low attenuation. Fat is low attenuation. What we are seeing here is a tumor. Now, tumor is always high attenuation. So understand this. A fat is usually low attenuation. Tumor, calcification, tissue, mass, hard things are usually higher attenuation. So something which are higher density, they more prone towards malignancy. Something lower density, less chances of malignancy. So that's how the density becomes important. Size we have to give always. Density becomes important. Now, shape, margin, and calcification also helps us to identify whether it is malignancy or not. So what density is usually malignancy? High density is always malignancy. What size? Size is usually can be any size, but more the growing size, more faster the growth in the size, then it is more chances of being malignancy. Any growth you see in a serial mammography, chances of malignancy is high, and as the size increases, the chance of malignancy is high. That's what we interpret by size. So density, higher chances of malignancy. What three things are left? Shape and margins and calcification. Okay, calcification we are dealing separately. In that calcification itself, I'll tell how to differentiate a benign calcification from a malignant calcification. Now, in this, we can see the shape and margin specifically. Now, in this, we can see this is a round shape. It can be oval shape. It can have lobulations on the surface, or it can be irregular in shape. Now, whenever there is a round shape, more like a cyst will be usually having round shape. And an oval shape will be usually a benign lesions, like a fibroadenoma will have this oval shape. Now, whenever there is a lobulations, then your chances of being malignancy slightly increases. But if it is irregular shape, very high chance of malignancy. Okay, so round shape, more usually cystic lesions or fibroadenoma, but most commonly cystic lesions. Oval lesions, more commonly fibroadenoma kind of benign lesions. Lobulated lesions, chances of malignancy cannot be ruled out. Irregular lesions, very high chance of malignancy. Okay, this is how the shape helps us. Now, in this lesion, we can see this is a cyst which is showing a round shape. Now, these are the oval shaped lesions we can see here, more like a fibroadenoma. Here we can see that the shape is irregular. Okay, you can see the side slide speculation is there in the outer margin, irregular shape, very high chance of malignancy. It is a case of an invasive carcinoma. So we can have a round shape or oval shape or irregular shape, or it can be or lobulated. So this is how the based on the shape. Now, margin is when the shape is the outer the border, the surface. Now, what margin is the difference between the normal structure to the lesion. Now, if the difference is very well circumscribed, it is very obvious circle, then it is usually benign, very circumscribed. If it is obscured, it can be benign lesion which is covered by some fibroglandular tissue. But if it is having these micro lobulations on the surface, then again it is slightly favoring malignancy. But if it is ill-defined or speculated, then it becomes more chances towards malignancy. So this is a cystic lesion, well-defined cystic lesion. Whereas here we can see that the cystic lesion might have covered on one side by the breast parenchyma, the fibroglandular tissue. Whereas here we can see these lobulations with hazy surface. We don't know the exact outline. We cannot draw a single line like this, like how we can draw a single outline here. We cannot draw such outlines here. It is slightly lobulated outer margin, and in this we can see it is very irregularly lobulated outer margins. So whenever we see this kind of lobulations, they are chances of malignancy. And whenever there are speculations like this coming out of the lesion, the chances of malignancy becomes very high. And density, as I told, higher the density, higher the chances of malignancy. High density lesion, we can see speculations coming out, very obvious chance of malignancy. And see the breast type 1 breast composition, very good to diagnosis. See this breast composition, almost type 3 breast composition. See, this lesion might have been missed if you wouldn't have seen properly. So this kind of breast parenchyma is not good, because it's a high dense breast parenchyma. Again, this parenchyma you see in between all these dense structures, we might have missed this lesion So, and also in this, you can see that this is a dense breast parenchyma. There is a benign fat lobule which is present. So fatty lesions, like, so it will be something like a lipoma. So it will be a benign lesions. So whenever the density is low like this, it will be a benign lesions. But whenever the density is higher, it is usually malignant lesions. And these high density lesions are we will have to identify in a breast parenchyma. So that is why we will not like a type 3 or type 4 breast composition. We like type 1 or type 2 breast composition for our good diagnosis. So again, now all the MCQs that we have covered here. So when do you say when a lesion is considered least malignant? When it has a circumscribed margin, when it has obscured margin, ill-defined margin, speculated margin. Very simple answer. It's a circumscribed margin. So in this pattern, which of them is considered as most malignant feature in a breast lesion? Whether it is a microlobulated, whether it is ill-defined, whether it is speculated. Very simple answer, speculated. Similarly, we can see even in the shape, which breast parenchymal lesion is most malignant. See, we will never have doubt in oval, round, but we'll always have lobulated or irregular. More irregular, it is more malignant, more speculated, more malignant. Very simple. We can characterize the lesions by these things. Very simple answer for a lesion. So whenever we see a mass, see the border, whether it is well circumscribed, whether it is not well circumscribed, whether it is having speculation or whether it is having microlobulations, and whether it is round, oval, lobulated, or whether it is irregular. So this is how we characterize the mass. Then once you see the size, is it growing? Chance of malignancy high. Then you see whether density, higher the density is high, but lower the density, less. Okay, so this is how we characterize the lesion. Now go to the calcification. Now, whenever we see a calcification, again in this we have to characterize this calcification based on the number, distribution, and then we divide it into benign, intermediate, and high probability of malignancy. Now, very simple. When do you call it a benign calcification? A very obvious calcification in a mammogram, a macro calcification in a macrogram is benign. Something that is easily seen is benign. Something that is very difficult to see, very fine, minute, tiny, they are more chance of malignancy. Some are in between, they're slightly bigger, but they're hazy. These comes in the intermediate. Very simple division. Now, let's see what are the benign calcification. When the calcification is on the skin calcification, it is usually benign. Vascular calcification, benign. If there is on the surface of the skin, benign. Vessels get calcified, atherosclerosis, benign. Popcorn calcification is benign, seen in the fibroadenoma or granulomas, and rod-like calcifications are benign. If there is a lucent central deposit, that means that some fat component is there, it will be benign. And eggshell calcification is usually seen in a cystic spaces or in a place where there is a fluid inside and outside, it will form a rim of calcification, benign. Precipitated milk of calcium, it is a milk of calcium, that is not a lesion, it is a milk. It will be floating. Okay, when you change the direction of the breast, it will change the shape. So that is the milk of calcification. Large dystrophic calcification, I told you, very obvious to see, it is benign. Okay, now skin calcification, whenever you see anything like this on the surface of the skin, that will be a benign calcification. You see some tags on the skin, benign calcification. Okay, now what we are seeing here is nothing but a vessel has atherosclerosis of the vessel, it can be calcified. Now the popcorn calcification seen in the fibroadenoma of the breast, again a benign condition. MCQ 2. Where do you see popcorn calcification? In the fibroadenoma, malignancy, very simple answer, it is fibroadenoma. Okay, now rod-like calcification, these are the rod-like calcification. Whenever we see this rod-like calcification, these are nothing but this has happened because of the ectatic ducts in which the secreted components will deposit there, and they will have this calcium deposited there, which will look like a rod-like calcification. Rod-like calcification, branching, it is usually a benign lesion. But the same branching, if you see in a tiny, fine calcification, tiny dots which are going branching, they are suspicious of malignancy. Branching calcification, fine calcification, looks, they are more features of malignancy. But rod-like calcification is benign. Obvious big calcifications are benign. So again, fat necrosis is a common place where we see this central hypodensity with surrounding calcification is lucent centered deposit. Now this is again benign, and axial calcification, the fluid surrounded by calcification. Milk of calcium, as I told, it will be the milk inside the duct and lobules. So whenever you change the position of the patient, mediolateral oblique view, the breast is made in oblique direction, you can see this classical saucer-shaped appearance of this calcification. That is milk of calcium. Milk of calcium. We can see this saucer-shaped fluid level. We can see in this. So that is the milk of calcium. Because it is denser, it will deposit down, and the fluid without calcium will be on top. It will have this saucer shape. Okay. Now this dystrophic calcification, coarse calcification seen in a radiation-induced breast after giving radiotherapy, or it can be because of the trauma, the breast would have damaged. Then again, we'll see this dystrophic calcification, again benign. Now, round calcification, this is a round calcification which is more than 5 mm. It is usually benign. So whenever there is a large calcification, whenever it is very obvious to see, these are all benign. When do I call it an intermediate type of calcification? When it is amorphous or when it is coarse. When it is amorphous or when it is coarse, we call it as an intermediate type of calcification. It will be when do we call it amorphous? When they are slightly bigger, but they don't have well-defined border. They'll be hazy calcifications, slightly bigger calcifications. Now that's when we call it as amorphous calcification. Now coarse calcifications are slightly more brighter, slightly larger they are, and they are very obvious. They are more denser compared to amorphous. So this is amorphous. This is also slightly larger, whereas a coarse is much more larger calcification, and it is more obvious calcifications. Now these are the intermediate calcifications, amorphous and the coarse calcifications. Whenever there is a fine calcification, it's a fine linear or branching or cluster of calcification, that is when we call it as a malignancy. You can see here fine clusters of calcifications, and they are linear somewhere. In some places, they are branching. So these are the calcifications which are more like a malignant classification. Multiple tiny calcifications, less than 5 mm calcifications, which are branching, linear, or if they are even present in clusters, then they are considered as more chances of being benign. So calcifications can be again divided into benign and malignant, and we saw it's very obvious macro calcification more than 5 mm, or it has a central lucency, or it's a rim-like calcification, or it is in the skin surface, or it is on the blood vessels, or they are rod-like calcifications, benign. When it is very fine linear branching, or whether fine clusters of calcification, less than 5 mm size, tiny calcifications, malignant. When they are slight in between these two, very tiny but slightly bigger with hazy margins, it's considered amorphous, and coarse calcification is slightly larger than amorphous, but it is seen very obviously very slightly denser than amorphous, then we call it as a coarse calcification. So a fine linear or fine calcification, just remember that fine calcifications are bad, tiny calcifications are the bad. Okay, now again, which of these are most malignant features? They can give you one as coarse, one is amorphous, one is fine linear or branching, one is rod-like linear or branching. Very simple. Fine linear or branching are the most malignant type of calcifications. Okay, any doubts you can keep asking in between. Okay, yeah. So next thing that we have to see is asymmetric breast finding. Now, so we know that whenever we see a lesion which is seen in 2 dimensions, and it is having convex border, it is considered as mass. So we see this as mass lesion. Whenever we report mammography, we call this lesion as mass. Now, whenever we are seeing some density which is not having a convex border, not seen in 2 dimensions, that's when we call it as asymmetric breast findings. Now, asymmetric breast findings are considered, there are 3 of them. When some density you are seeing in one weave, not in the other weave, we consider as asymmetry. When you are seeing it on 2 weaves but not having proper convex border, we call it as either global asymmetry or focal asymmetry. Now, focal asymmetry is when it is less than 1 quadrant, involving less than 1 quadrant. When it is involving more than 1 quadrant of the breast, it is considered as global asymmetry. Let's go see one by one. So this is when you are seeing the lesion in only in when you're seeing a lesion only in the one weave of the breast, the left breast, we are seeing in only on one weave, it is not seen in the other weave. So that then it is something that it is potential mass, but I cannot confirm it. See, I can see here it is slightly good looking mass here. Okay, probably it might be this one. Okay, probably it might be that, but I cannot clearly make it out whether it is the same mass or not. So that's when you call it as asymmetry. So you don't know, that lesion which was seen separately is not seen in this parenchyma, in this breast, because it might have been hidden in between this breast parenchyma. Okay, that will be the one reason. So in such cases, we can change the angulation of the breast and then take an image, or we can roll, that is called roll the breast and take an image, or take a different view. Instead of doing medial lateral oblique, you somehow with difficulty make it a lateral view and take it. That's when sometimes it will go away from the breast parenchyma. So these are the techniques to remove this asymmetry, and we can label it as a mass if required. So that's how we can remove the term asymmetry sometimes. So this is a lesion, a hyperdensity that I'm seeing in the left breast, in the inner aspect of the left breast, but in the mediolateral oblique view, I cannot see that lesion. I consider it as asymmetry. Okay, that is a simple asymmetry. These are all coming under asymmetric breast findings. First one we discussed is asymmetry. Next one what we discussed is global asymmetry. It involves the volume that is involved here is more than 1 quadrant of the breast, and it is seen in both the views, but it is not having this proper convex border. It is having more of a concave outer border. So that's when we considered it as a global asymmetry. So whenever we give this, we always compare it with the opposite breast. So this is the right breast. It is having, this is the fibroglandular tissue usually present here, but in this might be a normal fibroglandular tissue, but usually we expect both the breasts to have almost same amount of fibroglandular tissue. Because of some hormonal abnormality, there might be some overgrowth of the fibroglandular tissue. So that's why this is looking more dense. So it might be just a simple normal condition. Okay, we are seeing a large fibroglandular tissue. Now, this may be a simple benign condition, or it can be a mass. Now, whenever I get this kind of global asymmetry, what do? I do a breast examination. If I feel a lump, then it comes under BIRADS category 4, probably malignant. But if in case I don't feel a mass, it will come under the category of BIRADS 2. It is a benign lesion. Okay, so BIRADS will help us to distinguish this kind of normal findings also. Is it a possible malignancy or it is not? If it is palpable mass in this patient, it is possible malignancy. If there is no palpable mass, it is a benign condition. So that's how you grade the BIRADS whenever you see a global asymmetry. Now, focal asymmetry, as I told, it is involving less than 1/4 of the quadrant. Less than 1/4 of the breast is involved in this. Like the lesion is covering less than 1/4 of the breast, the size of the lesion. Now, in this again, we can see that, see, this is the fibroglandular tissue. This is the fibroglandular tissue. Here you are having a lesion. This is almost convex, but here we can have some concave border. So again, we cannot call it a classical the nodular lesion or convex lesion. So that's when we call it as a focal asymmetry. So this is a focal asymmetry. This is not looking like an obvious mass. Whenever it looks like an obvious mass, we call it like mass. When it's not being obvious mass, we can call it focal asymmetry. If it is large enough, then we call it global asymmetry. Now, if it is not seen only in one weave, it is simple asymmetry. Now, whenever we see a focal asymmetry, again you palpate. If you feel a mass, BIRADS 4 for probable malignancy. If it is not palpable any mass, then it is BIRADS 2. It is a benign condition. So this is how we see. Now, one more thing, whenever we see this kind of lesions, okay, focal asymmetry, you can do a follow-up imaging, or you can compare this with the old mammography. If the old mammography and this are having the same size, then we can directly put this lesion into BIRADS 2 category. We don't have to worry about the being malignancy. But if it grows in the next consequent mammography, then it is called as developing asymmetry. This is not a BIRADS lexicon. This is given the term coined by some other radiologists when they're reporting, when they saw that this growth of this asymmetry, they call it developing asymmetry. And whenever there is a developing asymmetry, it goes to BIRADS 4, needs a biopsy. Okay. Now we can see here there is a lesion here. Okay. And we can see, we can compare that in a craniocaudal view. Again, we can find that lesion, but it is not having a proper margin. We cannot see, we cannot identify the proper outline. It just looks like one area here. Okay, but we are seeing in both the views. So it is just nothing but a focal asymmetry. Okay, now whenever I do a compression weave, now it is becoming more obvious. It is becoming more obvious. Now, on ultrasound, there was a lesion and it turned out to be invasive carcinoma. Now, this becomes very important. Whenever there is some lesion or asymmetry, when it is not obvious on a regular weave, what we can do is we can take help of the additional weaves. Like I told, rotate the breast and take a weave, or we can make, instead of medial lateral oblique, we can take a lateral weave. And whenever there is a lesion that is not obvious, we can take a weave like this, in which we can compress the breast and take a weave. And even when you're taking oblique, we can compress it and take a weave. And if you want, we can magnify it and take a weave. So this magnified and compressed view, specifically compression helps a lot, because most of the asymmetry are because of the fibroglandular tissue are overlapping with each other. Now, when I compress it too much, the fibroglandular tissue will separate from each other. Whatever the thing that was looking obvious like a lesion will now disappear. Now that's how we take help of this compression to identify whether it is an actual lesion or not. Also, whenever we see any lesion in one weave, it should be from same distance from in the another weave. And whenever we see two lesions in two orthogonal planes, measure the distance from the nipple. Both should be from equidistant from the nipple, then they are the corresponding lesion. If they're not equidistant from the nipple, then either your technique is wrong or you have seen some wrong area. That is not the lesion. Okay, so that's why whenever we see, we always measure from the nipple and see where is the lesion. If the lesion is, say, equidistant in both the images, then that is the same lesion. If not, you are seeing something wrong. Measure the distance from the nipple to nipple, and then you mark an arc, and whatever the lesion comes in that arc is the expected location of the lesion. Okay. Now, whenever you see an asymmetry, it is simple asymmetry. Whenever the lesion is seen only in one plane, not seen in other plane, it is simply a BIRADS 1 lesion. It cannot be called anything. But if it is developing asymmetry, it becomes BIRADS 4. Whenever there is a non-palpable global asymmetry, BIRADS 2, or non-palpable focal asymmetry, it will be BIRADS 3. But whenever there is a palpable global or focal asymmetry, they comes under BIRADS 4. So this is a very simple classification of the BIRADS. So whenever you don't see a mass also, you just have to describe it as an asymmetry, and you have to tell what kind of BIRADS does it belong to. Very simple. So that is about the asymmetry. The next thing that we need to know is the intramammary lymph node. Now, intramammary lymph node, one thing that we have to understand is it is always in outer quadrant, outer upper quadrant. Less than 1 centimeter will be the size of the lesion, and it will always have a lucent area within it. What is this lucent area? Is nothing but a fatty hilum. The loss of this fatty hilum always suggests of malignancy. So this fatty area, this hypodense area in the middle of this lesion is a fatty hilum, which is not seen here. Chances of malignancy goes very high in this. Okay, if you see this low chance of malignancy, if you see like this nodules without any fatty hilum, chance of malignancy increases. So any nodule which are seen within the breast, we call it as a nodule if it is seen in outer upper quadrant, and you check whether there is a fatty hilum. If it is outer upper quadrant, less than 1 centimeter, fatty hilum is present, it is a benign lesion. Now, what are the other things that I can see? Now, this is a tubular structure that you are seeing. So this is again the tubular structure that is branching. It's either a linear or a branching structure. If we are seeing linear or branching structure, if you're seeing, they are nothing but a tubular structure. They are the dilated ducts. Okay, these are dilated ducts. But a malignancy cannot be ruled out in these conditions. So it will come under BIRADS 3 because close follow-up is required here, because the intraductal malignancy can be appearing like this dilated ducts with branching or linear structure. Now, whenever we see this, we'll keep it BIRADS 3, follow up in this patient. Other than whenever you don't see a focal asymmetry, you don't see a mass lesion, but you are just seeing these speculations. See, can you see these speculations? So that speculation means that there is some sort of fibrosis. If there is a old surgery, I can understand, yes, fibrosis can happen. But in a virgin breast, if there is speculations, then that means that there is something that is causing this fibrosis. Usually malignancy induces some amount of fibrosis. This kind of architectural distortion is very important to identify, see. This will give a clue that it can be malignancy. Now, what are the other things that you can see? Now, this other architectural distortion, lesion is there, it has retracted the skin retraction. Or if there is a lesion which is causing the retraction of the nipple, then again, that is one more thing that we can see. Then we can see the thickening of the skin. Usually periareolar skin thickening will be classically seen in some malignancies. And if you see some trabecular thickening, if you are seeing like how we are seeing in this image, if the trabecular thickening is there, then again it's chance of malignancy. Large nodules, lots of fatty hilum in the axillary area, again chance of malignancy is very high. So these are the different things that we can see in when we are doing a mammogram. Finally, after seeing all these things, that is mass, calcification, asymmetric findings, intramammary lymph node, tubular densities because of the duct dilatation, architectural distortion because of fibrosis, and which will lead to skin retraction, nipple retraction, skin tags, trabecular thickening, all these findings, then you finally come up with different categories. Now, whenever it is BIRADS 3, we do 6 months, 12 months, 24 months follow-up. If there is any growth, we put the lesion into BIRADS 4 category. Very simple. If there is no growth, then for 2-year follow-up, then we don't have to do anything. So that is about the breast mammography, how we interpret the breast mammography. If you have any doubts, you can ask, or we still have some 5 minutes left. If you want to take any cases, if anyone is interested, then we can take different cases that I have collected from our hospital. Or we can end the session now.
Dr. Prajwith, can we discuss some case scenarios, please?
Yes, I have case scenarios. So I'll show the case, but then someone will have to volunteer. If someone can volunteer for this case.
Yeah, I request Dr. Abib Shah, exam going PG. Abib Shah. or anyone.
Yes, sir.
Please raise your hand who is ready. Please try. Okay.
Yes,
Yeah,
sir.
just give an attempt.
Are you ready?
Whatever you can see. I'll.
Yeah, Abhiksha is there. Dr.
Okay,
Prajwith.
Abhiksha. See, I have given you craniocaudal view and mediolateral oblique view. Now, how will you interpret this image, and what are your conclusions? You just try to interpret whatever you can.
Sir, in the craniocaudal view, in the right side of the breast, it is showing high dense mass lesion, high
Okay.
density.
Okay.
Two lesions, one is big and another is small.
Okay, so see, I can help you with this. See, this is a craniocaudal view. So what you can tell is in the right breast, in the craniocaudal view. So whenever this is a craniocaudal view, this is the breast is compressed from superior to inferior. So whatever is in the outer aspect, this will be outer aspect of the breast. This is the inner aspect of the breast. Okay, so you can tell. So in the craniocaudal view of the right breast, on the outer aspect of the breast, I can see a larger lesion, larger mass lesion with what kind of margin it is?
Irregular.
Irregular margin. Good, it is having a irregular margin. Irregular surface. Now, what kind of surface it is irregular? What kind of margin you can call it? Lobulated, can you call it is slightly lobulated?
Lobulated, sir.
Okay. See, there is nothing like right or wrong in mammography, because see, there are some interpretations, they are dependent to the interpreter dependent. So you can tell whatever you feel like. Okay. So right now we have come up till this much. We have in right craniocaudal weave, right breast craniocaudal weave, I can see a hyperdense mass lesion with a irregular surface with slightly lobulated margin with some discontinuity in the margin on the anterior surface. Okay, so this much you can see. Can you see any calcifications in it?
Micro calcifications can be seen in the upper.
Try not to see micro calcification. You try to use fine cluster of calcification, because we just now we understood the BIRADS lexicon. We can call it as amorphous, we can call it as coarse, we can call it as fine. So try to use those terms. So you're trying to tell the examiner, I'm telling it more towards a malignancy, sir. So fine calcification, more towards a malignancy. Okay. So you're seeing good, you are doing really good. Okay. You're seeing a mass lesion in the right craniocaudal view on the outer aspect with the irregular surface, micro with the nodular margin, and we are seeing fine cluster of calcification. Okay. So this is one lesion. Describe. What BIRADS can you give for this? BIRADS category, what you can give for this?
BIRADS score 4, sir.
Okay, BIRADS 4, good. Okay, BIRADS score 4, good. It's everything is features are looking towards malignancy. 4 you can give for this. Now, what can you tell about this?
Sir, small, well-defined
Good.
mass with defined margins, sir.
Okay, circumscribed margin, good.
Probably BIRADS 2, sir.
Yes, good. See, that's how very simple it is. Okay, BIRADS 2 or BIRADS 1 it can come up to. Okay, we can keep in this setting, we will keep it BIRADS 2. Okay, what it can turn out, it can be a satellite lesion or anything. But for our discussion, it is a BIRADS 2 lesion because it is having well-defined margin, well-circumscribed margin, a circular lesion. It is BIRADS 2. So we have a BIRADS 4 lesion here, BIRADS 2 lesion. What about in this image? Can you see anything?
In the left craniocaudal view, we can see irregular margin with speculations.
Okay. We can see some asymmetry here.
Asymmetry.
Okay. Is it a focal or global asymmetry?
Focal asymmetry, sir.
It is a focal asymmetry. Good. Okay. It's a focal asymmetry you are seeing.
Yes.
Okay. And whenever, see this you are very obvious, you will see these lesions in other thing. Whenever this you are seeing, you also ask that I want to see a mediolateral oblique weave. Okay. Just compare in this as well.
Okay. So in mediolateral oblique view, right breast, it is having a small. Can we comment on lymph node status, sir?
Yes, you can comment on the lymph node status as well. You have to comment. It's not you can. You have to comment on the lymph node status.
Right mediolateral oblique view, we can round circumscribe lymph node can be seen, sir.
Yes, and what you have to tell here in this, we are seeing lot of loss of fatty hilum. You're not seeing any fatty hilum. So whenever given a chance, whenever you're thinking of malignancy, so you wanted to tell about the lymph node because you are thinking in terms of malignancy. So you also have to talk about the features of malignancy. You can tell this is small, but whenever it is large, you can tell, sir, there is a large lymph node in the axillary region, which might be probably more than 1 centimeter based on the appearance that I can see, and it is having lots of fatty hilum. So it might be a metastasis from the right breast lesion. Okay, so that's how you can describe it. Now, what one thing that you are not able to see here? What is that one thing that you're not able to see here? In this, you are seeing something which is not seen here. You're not seeing this smaller lesion which was present in the inner aspect of the right breast is not seen on the mediolateral oblique view. So what will you do next? In your hospital, there is only mammograph. What you can try doing there?
So, ultrasound we can use along with it.
Your hospital doesn't have ultrasound. You have only mammograph in your hospital. What you can try doing? See, now why is that lesion not seen here? Try to guess why is the lesion not seen here?
It is not compressed.
It is overlapping with the another lesion. Okay, it is overlapping with another lesion. So whenever, see, this is the lesion, they are separate. Okay, there one is front, one is back maybe. Now it is not seen because they're overlapping. So we can take a complete lateral weave. Okay, now we have taken a medial lateral oblique. We can take a complete lateral weave, or we can so whenever in a medial lateral oblique weave, we don't see anything, we take a complete lateral view. Whenever we are not seeing something in a craniocaudal view, we'll rotate the breast and take a craniocaudal view. So the tissues would have changed their directions. Now in this lesion, in this image, if I rotate the breast and take an image, what will happen? This nodule might go under the other nodule and get compressed in between. So you may not see that. Understand? Okay. When you rotate the breast in this view, craniocaudal view, if you rotate the breast, the lesion might be one on the other and you may not see. Okay. Same thing. Imagine if you are seeing only one lesion, actually there are two. So how to open it up? You just rotate the breast and take a craniocaudal view. So the lesion will open up. Okay. The same way the lesion is hiding behind the other one. So what do you do? Here, instead of rotating, what you do is you rotate the machine and make it more lateral, and mediolateral we will take. Okay, so that's one thing about this case. Okay, and what about this? Okay, here we are seeing an asymmetry. We are seeing a focal asymmetry with the irregular margin, speculated irregular surface, speculated margin. Okay, and if you see clearly, there are no calcification, but there is adjacent large calcification. What is your comment on this calcification? And always comment on this calcification. You cannot miss a macro calcification. So what is your comment on this calcification?
Broad-like calcification, sir.
Yeah, so what is it? Is it benign? So whenever, if you don't know what to describe this calcification, so that's when you can tell it's a nodular calcification, sir. So it more likely to be a benign calcification. Where and all it can be seen? It can be seen in case of a granulomas, or it can be a involuting fibroadenomas. So you can give these examples as well. Okay, so this is how we got a BIRADS 4 lesion, BIRADS 2 lesion. We have BIRADS 4 lesion, and here this is the BIRADS 2 lesion again. Okay, benign. Okay, understood?
Yes, sir.
Okay. Case to anyone? I'll give you a simple case. Okay.
Any volunteers, please? I request Mr. Gopi Krishna to volunteer to answer. So Gopi Krishna or Sumant Reddy?
These are the two images. Gopi Krishna, what
Right?
kind of breast parenchyma is it?
Yes, sir.
What kind of breast parenchyma you think it is? Here it is. Here it is fibroglandular. Here, okay, it's almost 25%. So type 2, right?
Type 2. Type 2, yes.
Type 1 or slightly type 2 breast parenchyma. You see the amount of fibroglandular tissue. Okay, don't worry, you can make mistakes now. Okay, even I do a lot of mistakes, so don't worry. Okay, so what is this now you are seeing? Is it a mass? Can I call it mass?
Yes, sir. It looks like a mouse.
Convex surface. Is it convex surface? It's having convex surface, right?
Yes.
It is having convex surface. What about this margin? Is it well defined or is it like ill defined?
It is not well defined.
Not defined. Okay. And is it circular oval or is it irregular margin? Irregular shape.
Irregular, yes.
Okay. It is an irregular shape. It's ill-defined margin. It at least at the inner aspect. Okay. And you can see in the the mediolateral oblique view also. Okay. Now tell me, where is this lesion located? Where is this lesion located? Is it inner aspect or outer aspect? If this is the breast, is it in the inner aspect or outer aspect? Okay, if you see, whenever we see the image like this, the upper side, okay, is always outer. The upper half is always outer, and in a mediolateral oblique, the upper half is always lateral. Superior and outer. Upper aspect is always either superior in mediolateral oblique or it is outer in craniocaudal view. Okay, so we divide the breast into outer half and inner half. So you are seeing a partially ill-defined mass lesion which is having irregular border, which is seen on the outer aspect on craniocaudal view and superior aspect on the mediolateral oblique view. So it is in the upper outer quadrant of the breast with ill-defined margin, irregular surface. What do you think it is? Now all these features what I described, they favors what?
It's malignant.
It is malignant. So out of BIRADS, which category? Mainly we have to talk about 1, 2, 3, and 4, which
It's
is
4.
telling it is malignant.
BIRADS 4.
BIRADS 4. Okay. So you can tell right upper quadrant breast lesion, BIRADS 4. Okay. So what do you see in the PET CT images? Is it malignancy or not?
Yes, it is malignant.
Okay, PET showing uptake, so it is malignancy. Okay. So that was the second case. Does anyone want to take next case? Next case, anyone want to take? Anyone? Okay, this is a easy case.
Abhipsha, can you?
Yes, sir. Sir, in the right breast craniocaudal view, outer surface,
Yes, please.
outer quadrant is showing a irregular speculated mass-like lesion.
Okay.
With,
See, first thing is, if you are calling this as a mass-like lesion, that doesn't look like mass-like. Okay, it is having more like a. See, it is not having classical, circular or convex margin is what we call it. It doesn't have that convex. Okay, and you are seeing this kind of tissue here, this kind of tissue here, this kind of tissue here, this kind of tissue here. So you are seeing a large area of hyperdensity, correct?
yes, sir.
Large area of hyperdensity. Is it seen here? Not that much.
Not that much.
It is not seen that way. Okay, so you're seeing the right breast predominantly areas showing what? Hyperdense areas. Correct? Is it covering less than 25% of the breast or more than 25%?
Than 25%.
It is?
Less than 25% of the whole breast.
If you okay, if this you are considering so much, the quadrant, if you are considering, it will almost up to 25%, we can call it. Okay, it is not having proper convex border, it is having concave border. See here, concave, concave, concave. It is not having convex borders. So what is it? It is not a mass. We can call it as asymmetry. Okay, now this asymmetry is seen here or not? It is seen in this also.
Yes, sir.
Okay,
In
it is.
lateral view, it is showing asymmetry.
Okay, it is seeing in both. It's almost up to 25%. Okay, whenever there is a large asymmetry compared to contralateral breast, and whenever you see this large asymmetry compared to contralateral breast, we can call it as a global asymmetry if you want to call. Okay, you can call it as a global asymmetry, but we don't call it because only in this view it looks like not breast parenchyma, but here we don't see it. But if I see the mediolateral oblique view, I can see the parenchyma here, I can see the parenchyma here. It's almost the equal parenchyma. Okay, so we don't call anything. That is not an asymmetry. What you have to concentrate next is on this region. Can you see something here?
In the left craniocaudal view, not uniform, sir, speculated
Yes.
margins.
Is it well defined?
Not well-defined margins.
So you have to tell you are seeing an ill-defined lesion with speculated margin. Seen where?
Seen in the outer outer quadrant.
Outer quadrant. So in this, where is it? So this will be the nipple and this will be the breast. So this will be superior. This will be inferior.
Superior
Yeah.
outer
So
quadrant.
this is good. So you picked it up. This is the lesion. Okay. So it is seen in the upper outer quadrant. Good. You are doing it good. So you saw a ill-defined lesion with ill-defined asymmetry, asymmetric lesion, breast lesion with ill-defined margin, ill-defined surface, speculated margin in the upper outer quadrant. So what is it? What do you think it is? BIRADS?
BIRADS 4, sir.
Do you think?
Mm,
Very simple. BIRADS 4.
4, sir.
BIRADS 4. Good. Okay. So that's how you interpret this lesion. Okay. So you saw this BIRADS 4 lesion in the upper outer quadrant. Then you can see some large lymph nodes here. You will have to. Some are showing hypodensities within, which might be artifactual or it can be a normal fatty hilum. So I cannot conclude that whether it is metastasis or it is just a normal lymph node. Okay, so this is how you interpret. So whenever you start reporting, you will have to comment on the breast parenchyma. After you comment, this is what kind of breast parenchyma do you think? Type? Okay, type 1 or type 2. Okay, that is not having so much of breast path. This may be almost 25% of the breast is involved. So whenever it is 25 or above, it becomes type 2. Less than 25%, it becomes type 1 breast parenchyma. Okay, so that was the one more case. So this is how we interpret the mammography. Very simple. When we see any lesions, you see whether it is a mass or whether it is a asymmetry. Okay, mass or asymmetry. If there are any other features that are favoring malignancy, like fine calcification, architectural distortions, the skin thickening, any of these features are present, then you favor it towards malignancy. And whenever it is mass, again you describe the different surface, the surface of the mass, the margin of the mass, describe the density of the mass, size, and that's how you again divide it whether into benign or malignant lesion. Whenever it is type 1, it is a normal breast. Type 2, it is a benign breast. Type 3 is probably benign. Type 4 is probably malignancy. Type 5 is highly probability of malignancy. Type 6 is biopsy proven. Okay. And whenever it is type 3 or above, it is of concern. Type 3 needs regular follow-up. In the follow-up, if you are seeing the growth in the size of the lesion, then we are putting it on a type 4. We need a biopsy to do biopsy and we confirm it. If you are not sure, then we can do an ultrasound and we can see. Whenever the breast is of type 3 or type 4, always additional ultrasound will be helpful to reduce the false negative findings in the imaging. So thank you everyone for